My name is Dr. Vijay Aswani, practicing clinical and aesthetic dermatology since 28 years in Mumbai. Today, I would like to talk about superficial fungal infections. There has been an increase in the prevalence of dermatophytosis over the past 5 years. The standard treatment recommendations which we have been following are no longer valid. Environmental factors, erratic use of topical and oral antifungals, increased prevalence of T. mentagrophyte infection causing inflammatory lesions and probably a growing resistance to antifungal agents may play an important role. We are seeing changing clinical patterns. There is an epidemic of steroid modified tinea in India. Steroid containing creams are available over the counter and are used by patients to mitigate symptoms. The cutaneous inflammatory response is suppressed by topical and oral steroids. This is required to resist and limit the fungal infection. Concomitantly, there is local suppression of T-cell mediated immune response to the dermatophyte. These two factors are responsible for the changing clinical patterns. Complete central clearing does not take place and the lesions continue to spread centrifugally. Multiple concentric circles develop or eczematous patches develop in the center with peripheral spread. Large size lesions and multiple lesions are seen in an individual patient. Children also present with large sized lesions and involvement of multiple sites. More number of tinea faciae are being seen, as also an increased number of adult tinea capitis. We are seeing more number of erythrodermic variants of tinea corporis, and most of these patients are immunocompetent. Most frequently side effects of steroid modified tinea are striae, atrophy, hypopigmentation and telangiectasia. We are seeing a changing scenario of dermatophytes. Trichophyton mentagrophytes has emerged as the co-dominant pathogen along with T. rubrum with an increased prevalence in comparison to what was seen in the past. While treating these patients, we have to use higher doses for a longer time. Topical creams have to be used for a longer time. Stopping the therapy before 3 weeks is associated with reappearance of pre-existing lesions or even new lesions at other areas. Weight-based dosing of oral antifungals instead of a blanket recommendation is found to be more beneficial. Griseofulvin is used in a dose of 500 milligrams per day orally in single or two divided doses. The usual pediatric dose of the micro-sized formulation is 15 to 20 milligrams per kg per day orally in single or two divided doses. Fluconazole is recommended in a dose of 150 mg twice a week until cure. In extensive tinea, recalcitrant tinea and in recurrent tinea, it can be given in a dose of 150 mg daily for 2 weeks, followed by 150 mg on alternate days for 2 weeks, and then twice a week until cure. The usual pediatric dose is 3 to 6 milligrams per kg per day. Itraconazole is recommended in a dose of 100 to 200 milligrams twice daily until cure, and the pediatric dose is 5 milligrams per kg per day. Terbinafine is also used in a dose of 250 milligrams per day until cure. Pediatric dose is 10 milligrams per kg per day. Ketoconazole is a very old molecule and is being used for treating tinea these days in a dose of 200 milligrams per day, and the pediatric dose above the age of 2 years is 3.3 to 6.6 milligrams per kg per day. Topical antifungals should be used properly and for at least 2 weeks beyond clinical resolution. The general measures which have to be taken are as follows. T. mentagrophyte survives for greater than 25 weeks while T. rubrum survives for greater than 12 weeks on a towel. That is why disinfection of clothes should be done by washing in hot water at 60 degrees centigrade and drying in sunlight. In the absence of sunlight, ironing can be done. Avoid sharing clothes. Loose fitting clothes, socks made of cotton and boxer shorts in patients with tinea cruris should be preferred. Occlusive footwear should be avoided in patients with tinea pedis. Antifungal powder can be applied in the web spaces. Any physical activity leading to excessive perspiration should be followed by bath and changing into dry clothes. Humid areas such as bathroom floors should be cleaned and kept dry. Dusting, wet mopping or vacuuming the house followed by cleaning with detergent should be done on a regular basis so as to reduce the spore load. One should avoid walking barefoot, especially in a public place. Infection from animals, pets should be considered. Chronicity can develop if patient is continually re-exposed to untreated family members. One should avoid sharing combs, scarves, hats and pillows with the infected individual. Regular trimming of nails should be advised. Now, recurrent infection in the patient is because of increased spore load in the family, increased virulence and infectivity of the organism, and the role of fomites. The practice of sharing the prescription of one family member with others should be discouraged as it leads to incomplete therapy and increased resistance. All this puts a financial burden on the family. All these factors have to be borne in mind while treating patients with superficial fungal infections, which has become a scourge of recent times. Thank you.